behalf of all regional telehealth resource centers, we welcome you to our monthly webinar. The Heartland Telehealth Resource Center is extremely excited to host this month's webinar, and it will provide you with some excellent information regarding Project ECHOs in our region. But before we get started, I'd like to introduce you to the telehealth resource centers. This map shows our presence across the nation. There are 12 regional telehealth centers, so please take a moment to locate yours. And then there are 2 national centers, one that focuses on policy at the Center for Connected Health Policy in Sacramento, California, and one that focuses on technology at the Telehealth Technology Assessment Resource Center, more affectionately known as TTAC, out of Anchorage, Alaska. The telehealth resource centers are funded through the U.S. Department of Health and Human Services, Health Resources and Services Administration, which is part of the Office of Advancement for Telehealth, which is part of the Office of Rural Health Policy. So, in other words, we're federally funded. Telehealth resource centers, in some shape or form, have been around for about 10 years, and we were established to provide assistance, education, and information to organizations who are interested in providing medical care at a distance. So our mission is to expand availability of healthcare to underserved population. Access to healthcare is what we're about. And because we are federally funded, the assistance we provide is generally free of charge. So some logistics for today's webinar. Number 1, you will notice that you are all muted, so no worries there. Number 2, if you have content questions for our speakers, please use our Q&A feature at the top middle of the screen. Just type in your question and we will do our best to answer those questions. The speakers have asked that we do that as we go. If we get a little overwhelmed, we may stop that process just so we can get the content in. If we don't get to all of the questions, we will certainly follow up with you and do our best to get back to you as soon as possible. Number 3, if you have technical difficulties, here is a phone number. So get a pen and pad ready and we will do our best to assist you. Technical difficulties, please call Becky at 317-517-3961. I'll say that one more time, 317-517-3961. We don't expect any technical difficulties, but if it happens, then you have a number there that we can work with. So, this month, the Heartland Telehealth Resource Center presents ECHO in the Heartland. For those of you new to ECHO, that stands for Extension for Community Healthcare Outcomes. We have 2 national leaders as today's presenters in ECHO. Rachel Matrew from the University of Missouri, Senior Program Director and Director of Missouri Telehealth Network, as well as the Director for Show Me ECHO. Dr. Evelyn Nelson from the University of Kansas Medical Center. She is the Director for the Center of Telemedicine and Telehealth at the University of Kansas, as well as Director of Project ECHO. Rachel has agreed to go first today, so we will let her take it away. Rachel.
Okay, hi everybody. I finally figured out how to see who all was on, so welcome. Give me just 1 second while I can share my screen. Okay, can you see that? Great. So I'm going to talk today about Project ECHO, and here is, let's see if I can figure this out now. Hold on. This is me. I think, thanks Janine for the nice introduction. I'm the program director for the Missouri Telehealth Network. I also run our project Show Me ECHO. And then for the Heartland Telehealth Resource Center, I'm the one of the Missouri people to help folks in Missouri. I've been doing this for a while. I've been practicing or working in telemedicine for 14 years, and I've been the director of Missouri Telehealth Network for 10 years. And that's how you get a hold of me if there's anything I can help you with later. So today we're going to talk about what is ECHO, the ECHO projects in Missouri, and then I have one slide with some advocacy tips in case anybody wants to try to start their own ECHO projects. The picture that you see at the bottom of that slide shows one of our ECHO projects. This was our very first one that we started, and it is the chronic pain management ECHO. And ECHO is when you have an interdisciplinary team, and so that group of people is an interdisciplinary team for chronic pain management, and they connect to primary care providers, which you might be able to barely see in the background of one of those other pictures. So it is a telehealth project, but there are no patients present during an ECHO. So just to get started, so we're all kind of on the same page, we recently redeveloped our mission statement for Missouri Telehealth Network, and I wanted to put that side by side against the Project ECHO's mission statement because we have that mission on our ECHO project, but for Missouri Telehealth Network, it's a little bit different. But you can see where they could blend together. So here at Missouri Telehealth Network, our mission is to develop, study, and use telehealth solutions that improve access by providing high-value, patient-centered healthcare and medical education in Missouri and beyond. And then for Project ECHO, they have a little bit bigger mission than that, than just Missouri and beyond. The mission at Project ECHO is to democratize medical knowledge and get best practice healthcare to underserved people all over the world. That's a pretty lofty goal right there. Okay, so this slide gives me the opportunity to tell you really what ECHO is. So ECHO stands for Extension for Community Healthcare Outcomes. It was founded by Dr. Sanjeev Arora, who's a hepatologist at the University of New Mexico, and he had a really long wait to get into his Hep C clinic at the university. It was probably, I think it was 7 or 10 months or something, it was long. By the time those Hep C patients would get into the clinic, they were sicker than they needed to be, and he got very frustrated that he couldn't help these patients, that there was, through no fault of their own, they couldn't get in to see him and start treatment earlier. So he decided to look at it a different way, and he said, like, you know, this isn't brain surgery. A lot of people can treat hepatitis C. So at that time, the drugs that they used to treat Hep C were a lot like a chemotherapy. They made people really sick. They caused some depression. And so he didn't want to just let primary care providers loose on treating Hep C because it wasn't something that's normally managed in a primary care clinic. He wanted to help them build trust, build a relationship, get an interdisciplinary team together, and help them manage those hepatitis C patients that were at an acuity level that he felt like it was safe and effective for them to do. So he got together with an interdisciplinary panel, like I said. So he had a pharmacist, a psychiatrist, a social worker, maybe a nurse, and himself, a hepatologist, on a panel. And he went around the state and got volunteer primary care providers. He said, well, who wants to treat Hep C in your own community? And he got maybe, 15 or so primary care providers that said, sure, I'll do that. And they present, so the primary care providers present their own case. So they find a patient of theirs that's Hep C positive. They gather about 20 different data points, and they present it to that panel over video conferencing, just like they did in medical school. So they might say, I've got a 43-year-old white male with hepatitis C, and then on and on and on about the different specifics. And then everybody on that interdisciplinary panel and all the other primary care providers get to ask clarifying questions. Like they might say, is this person still using alcohol, or are they still using drugs? And they get to the bottom of it, and then at the end of that conversation, then the primary care provider receives a very specific set of recommendations that they can go back and use with that patient. And then another provider presents their case, and then another provider presents their case. And there's also a short didactic session in each one of these clinics. So we call these Show Me Echo clinics, but there are no patients at these clinics. There's only patient data. So over time, all the primary care providers learn from each other. They learn from the specialists learn from the primary care providers. And all of a sudden, instead of having one academic health center that's treating hepatitis C, you've got 16 places across the state that are treating hepatitis C. Dr. Arora did a study on this to see if the outcomes, that O in ECHO is outcomes, so we always want to measure our outcomes. He did a study to see if the outcomes with the primary care provider group and the academic medical specialists were the same, and they were. And he published those results. And then he said, well, if we can do this in Hep C, why can't we do it in other disease states? So that was about a little more than 10 years ago that he started the project. And now there are echoes in more than 40 different subjects, or with more than 80 different entities. So lots of places around the United States, many different countries around the world, and then the Department of Defense, the VA, all these organizations see the value in this very simple idea. When we talk about what disease states or conditions that work well with Hep C, we talk about the 4 C's. Diseases that are common, costly, chronic, and complex. I bet we can think of a bunch that fit that description. Maybe diabetes, maybe that would work for that. So there's a lot. And the way that we use ECHO, just to go back one more time, this is a telehealth project. Even though there aren't patients there, it's a telehealth project. You're using video conferencing to improve people's health. It's a disease management model that would reduce the variation in care and expand the best practices more quickly. It's case-based learning, so it's learning by doing, which is a much better way to learn than reading about a new treatment in a journal. I'm not a doctor, but I would guess that that's true. And then we do monitor the outcomes in this. It's very important that we monitor the outcomes to make sure that we're accomplishing our goals. That's a nice picture. That's an oldie but a goodie, but that's Dr. Arora and where he used his back is to us. But you can see on the TV on the left-hand side, there's a bunch of different places that are joined. On the right-hand side, that's data during his didactic presentation. Does that all make sense to everybody so far? Can I get some thumbs up? I don't see very many people. Thanks. Okay, the ECHO cycle of learning. I did this. I hope it makes sense to you guys. It kind of makes sense to me. So the specialists share their knowledge, and they partner and mentor with the community primary care providers. And then those primary care providers get to take care of their own patients with chronic conditions. Not all of them. Some of them will still have to go to the specialist, very acute patients. But for more patients, they'll be able to take care of. And that allows those communities, remote communities or urban communities, to have the capacity to take care of their own people. And I think that that's one of the big things that makes this project so special, is that it builds community support. So there are lots of benefits of Project ECHO. One of the things that I put at the top here is that we do provide CME credits for all of the participating providers. But even more importantly, the primary care providers get professional interaction. They get to be part of a learning collaborative that they weren't part of before. They get to meet people with the same problems that they have. And I have got a story about that I'll tell you in a little bit. They get to introduce learning back into their workday, which is really important for primary care providers who have been, their whole life so far they've been learning. All of a sudden they go to a community and they start working, and that's all they do. They don't get to learn anymore. And then they also get the access to specialty consultation. And that is that in those interdisciplinary groups, every person on that panel gets their cell phone number and gives it to every primary care provider. So anytime you have a question or you need to text somebody about something, you've got somebody on your phone that you can get a hold of, somebody that you probably didn't know before. ECHO has lots of benefits for the whole health system. This is the health system with the big capital H. By reducing variations in care, you can imagine that we would have a cost reduction over time to the big health system. we increase access to rural and other underserved patients. Because if they had to wait 7 months to get into the doctor, they might be super sick. But when you have Project ECHO and you have primary care providers providing a lot of that specialty care, then the patients can get in to see them. ECHO is a force multiplier, and that goes back to when I said earlier, you know, we had one academic medical center in all of New Mexico treating patients with hepatitis C. And then after this implementation, after a couple years, that went from 1 center to 20 centers. I mean, the power of that is just unbelievable. It demonopolizes the knowledge of the specialists. So in our current model of healthcare, these specialists go to school for an unbelievably long amount of time. They're kept up to date in their own subspecialty area through the process of going to meetings and working with their colleagues. But that information stays in their own head, and it's really hard to get that out to the primary care. That's what ECHO does. It partners those specialists with primary care providers that have a certain passion or interest in a certain topic. ECHO can improve professional satisfaction and recruitment and retention of primary care providers in rural areas. There has been a paper done on that from the University of New Mexico, and in Missouri we hope to study that as we go forward. ECHO obviously can support the medical home model by bringing together all these specialists around a certain disease state or condition and that the patient needs. And you can read the rest of those, but we're improving quality and safety. We're reducing excessive testing and travel. So in Missouri, we've been doing telehealth for a long time, since 1994. I haven't been here that long, but we know telehealth is great. Telehealth does increase access. So we've been doing teledermatology since 1994. There are patients that would never been able to see a dermatologist if we didn't have teledermatology. Telemedicine does improve economic benefits in rural areas, but it does have its limitations. And the limitations that I see are that with telemedicine, you still just have one doctor and one patient, and then the same doctor and another patient, and then the same doctor and another patient. So while you are increasing access to care, you're not increasing the capacity of that specialty in your state. In other words, you're not multiplying your dermatologists or your endocrinologists. All you're doing is taking the care directly to the patient. I shouldn't say all you're doing. That's an important part of it. But what ECHO does is it increases the capacity for care. Does that make sense to everybody? So what we're doing here in Missouri is we're layering ECHO on to our existing telehealth services. We've always done continuing medical education through grand rounds and other CME things. We always have done, you know, any kind of training or administrative meetings. We've done outpatient specialty care forever, and now we have ECHO on top of that. So just a little bit of background about how we got started in Missouri is a couple years ago, it was December of 2013, we, myself and my medical director, Dr. Karen Edison, went to New Mexico for 1 day, they call it introduction. And they don't charge anything for it, but you have to get yourself there. So you go down for a whole day and learn about ECHO. And we went with a group of legislators, majority party legislators here in Missouri in December. And we were just sold on the idea that this could transform healthcare in our state at a very low cost. And so we came back, and in January, one of the legislators that went with us introduced telehealth legislation to create Show Me ECHO under the Missouri Telehealth Network. So we got that Show Me ECHO put in. We also, in a different appropriations bill, we got $1.5 million put in to start ECHO. Now that year, the governor vetoed all new spending, so we didn't get that money. But the next year in 2015, well, and we were so excited, by the way, in 2014 that we didn't care that we didn't get that money. I mean, we did care. But we decided to move forward with our ECHO projects anyway, and we started 2 pilots. We started chronic pain management pilot as a partnership with the Missouri Primary Care Association, and we started an autism ECHO with just pooling together money from various sources, including we got some funding from one of the Missouri managed Medicaid companies to help us with that pilot. And then, so we got those 2 pilots started. By the next year, we got the 1.5 million put back in. It was signed, and so as of last July, we have started 6 ECHO projects, and I'll talk more about those in a second. I will say that our first year has been going so well, and right now we're still only like 8 months into it, or 9. But we, for the next year, our legislature have doubled our funding. So we now have $3 million put in. All we need at this point is the governor to sign off on that. So the bill is on the governor's desk. And so we should be able to do at least 6 more new ECHOs. So yay, very excited. So one of the things that I found so exciting about ECHO is that it perfectly overlays with what we do as a telehealth network. So everything that you do in ECHO is pretty much exactly the same that you do in for telemedicine. So we have to train providers, we got to help run clinics, we got to create reports, we have to, it's video conferencing, we have to do all this coordination. And it's the same relationships and network that we've already built. So we already have partnerships with the FQHCs and RHCs and Medicaid and the health systems and the hospitals. So the map, the Missouri map on there, those red counties are counties that, as Missouri Telehealth Network, we already had partnerships in those counties with all different kinds of healthcare organizations. So starting our new Project ECHO, it was much quicker for us because we already had these relationships built, I would say. So these are the 6 our ECHO projects that we've started this year. Our asthma one is a childhood asthma project. The autism one is ongoing. It's going really great. The chronic pain management one, dermatology, endocrinology with a focus on hard to manage diabetics and hepatitis C. I'm going to see how we doing on time, you guys. Doing okay? All right. So just a little bit about the chronic pain management one and the asthma one, just so you know. I think I have it. It might be on a slide down here. So we are evaluating all these very carefully because of the O in ECHO is outcomes. We need to be able to go back to our funders, which in this case is our state, to show them how valuable this project is. So under the chronic pain management pilot project, which was a 6-month pilot, we looked at the chronic pain patients in 2 different federally qualified health centers. And we looked at 4 different cost areas for those 2 centers. The 4 cost areas were inpatient hospitalizations, emergency department visits, prescription drugs, and outpatient visits. And with those 2 health centers over a 6 months period of time, we looked at them 6 months before the start of the ECHO and during the 6-month pilot. So 2 cost centers went down and 2 went up of those 4 different areas. So emergency department visits went down, inpatient hospitalizations went down, prescription drugs went up, and outpatient visits went up. Now, the dollar amount, though, is not even. It's not 2 went up and 2 went down. That showed a total net cost savings of $1.5 million for 6 months with 2 health centers. So with that kind of data, even though it wasn't completely verified and we have to go back and check and make sure that it was the ECHO that made that change, we could still take that to our state and say, this ECHO is working. It appears to be working. We hope it's working. And these costs went down. Those are real numbers. And then also in the asthma project, which has been going on a little bit longer, basically we took an asthma project where they used to go in person and train these groups, these different clinics, and create what they call asthma-ready communities. And now with the power of ECHO, they can train many different communities at once. And with that project, we can show a decrease of about 60% per patient per year in cost spending. So a child with asthma in Missouri spends an average of $4,300 per year in the healthcare costs. after we do implementation and training of these primary care providers and get them on board with understanding asthma better, that goes down to less than $1,500 a year. That's a huge cost savings. And that's the kind of thing when I say we're going to get best practice out of the head of these specialists and out into the communities, it's going to have a huge impact. So under evaluation and data, what we're doing here in Missouri, we have access to the Missouri Medicaid claims data. We're utilizing that in every single echo we do to get a better handle of where we're spending money and where we can save money, and practice patterns, so we will know who's prescribing what kind of drugs, and can we help them do a better job with that. We're looking at self-efficacy, which is a fairly common measure across all the ECHO programs across all the United States, and that's measuring how providers feel like they can do in a specific disease state or condition. Can they diagnose it? How confident do they feel in diagnosing it and treating it? And lots of other things you can see there. The evaluation and data are really, really important on this. This is kind of the last slide. This is my advocacy slide, and I just learned this, so I'm trying to say it as much as I can, so I remember it. I learned this when I was in New Mexico, and this three-pronged approach to advocacy, I don't know if anybody else has seen this before, but they talk about the ethos, pathos, and logos. So when I'm going to talk to legislators, then I need to hit all three of these areas. So under the ethos, it's like, okay, you're going to do the right things. You're appealing to people's ethics and morals. So, you know, increasing capacity to healthcare is doing the right thing. The pathos is like, you know, empathy. So that's when we use our provider stories and our patient stories. So I've got this really great story. It doesn't take very long. You guys are going to love this. So we had, under our dermatology echo, we have primary care provider group that's only like 30 miles outside Columbia. Well, they presented this patient on the echo, and it's a picture of this lady's leg, and she had gotten spurred by a rooster. So I don't know, I mean, it's not that common of an injury type, but this primary care provider had treated her over 4 months with 4 different antibiotics, and it wasn't better. And the very second that they flashed that lady's leg, a picture of her leg on the screen, we had 4 dermatologists on our echo clinic that day. They all knew what it was in one instant, and it wasn't what that primary care provider thought it was. So they had tried 4 months, you know, that patient had been in, I don't know how many times to see them, 4 different antibiotics, not better, and it wasn't, they had diagnosed it incorrectly. That's the kind of thing, I mean, that's pain and suffering to the patient, but also the provider, think how many more patients they could have seen had they had that information. And not only did that one provider learn what that diagnosis was, now all the providers, all those primary care providers that joined that day, they all know that now, and they'll all remember, you know, the rooster spur story. That's why those stories that you don't forget. And then the last one on that is the logos, the logic, and that's the cost savings and the return on investment. And that is the area that we're working really hard to make sure that we have, you know, the claims data from the university. So I think that was my last slide. Yeah, so I'm going to stop sharing, and then if people want to ask questions, I'd be more than happy to take those.
At this time, we have no questions. So I'll, you know, kind of give them another tutorial. If you take your cursor and run it at the top of your screen, you'll come up with the Q&A session. So you can type in your questions and we can answer those. But apparently, oh, here we go. I've got one question, Rachel. What kind of organization needs to start a Project ECHO? Does it need to be a university?
I would say that it doesn't have to be an academic medical center, although that's where you tend to find some of these specialists that you need, but not necessarily. So we're going to start one in pediatric and adolescent behavioral health, and we're partnering with a community mental health center specialist on that. So no, it doesn't have to be. Right now, I would say mostly what you see are governments, large organizations, and academic medical centers, but it certainly doesn't have to be. In fact, I will say, and others on the call know this a little bit, but there are school-based echoes that are training teachers on different things that I find very interesting.
While we're kind of waiting on questions, and I see a couple more come in, I'm going to go ahead and do this first poll. So here we go. Previous to this webinar, I had heard about echo, yes or no?
Hey, is it okay if I answer one of these questions? I didn't really go into the way that echoes are funded or what they pay for an echo. The reason why echoes are so cost effective is what you pay for in an echo. There are two cost areas in that. One is to pay a percentage of that specialty team's time. So you might pay 10 to 20% of each one of those experts' time. And then you go to pay for operational support, including evaluation and research. And so like the team that works for me, that's the operational support. So those two costs are all that you would pay for that.
That's great. Thanks, Rachel. What did you learn that surprised you most?
I would just say that the thing is how fast it's growing. So if I would encourage everyone on this to go and watch Dr. Arora's TED Talk. It's just fabulous. It's 10 minutes out of your life that's well worth it. But he has a goal, and I feel like I'm part of this movement now. He has a goal of echo touching 1 billion lives by the year 2025. And I really think that we're going to make that. And I think that if you go out there and you start working on this project in your own area, your own group, you can do it because it just doesn't take that much money. We've been talking to the foundations in Missouri. They're fully supportive. I think foundations in your own state, because this is a low-cost investment where the technology is basically free, then a lot of people can get these started.
Absolutely, and people do become very passionate after going and listening to Sanjeev Arora's talk. He is he's really on the money there in terms of on the mark of where we need healthcare to go. Jared has a question, and this is a good one. It's something that sometimes we've had trouble with. How do you recruit participants?
Yeah, so recruiting participants, I would say, is the hard part because you're not paying the primary care providers to join. You're trying to get their buy-in because they'll get to be part of a learning collaborative. And they get to have fun and they get to help manage their own patients. I've heard a primary care provider that's part of our autism echo that says, she says, like, this is unbelievable. I thought I was the only one. She said, I thought I was the only one that had these patients and had these issues and had these families that were so desperate for information. And now she feels like she can handle that. So you've got to find the right people.
Absolutely. Absolutely. How about echoes that cross state lines? That's a good question, Jared. Thanks for that.
There are lots of them. Any that aren't funded by a state, like mine's funded by my state, so I have to stay in the boundaries of my state. But there are lots that cross state lines. MD Anderson is doing some echoes. There's another big Texas health system that's doing some cross state echoes. Obviously, the VA and the DOD are. It just depends on how the funding is. And then I think in Kansas, your AAP funded.
I was going to chime in that we were fortunate that the National AAP funded our Pediatric Epilepsy ECHO. So that's a joint across the state and really across the country. Anyone can join. It's a collaboration with Children's Mercy Hospital on the Missouri side and University of Kansas Medical Center on the Kansas side. It's really been a success. So we'd be glad to have folks join that one. I'll talk a little bit more about that in a minute.
Great. Let's answer a couple of more questions and then we'll hand the program over to Evelyn so that she can give her 2 cents about her ECHO project. Do you file to insurance? Kristen wants to know. If so, what codes do you use and what insurance carriers pay for these services?
No, this isn't. This is a program that doesn't, it's not direct clinical care. It would be more like a grand rounds presentation that you take your patient and you present it as a grand rounds case. And that's how I would compare it. Evelyn or somebody else on the call might have a better or a different viewpoint, but none of these are billable visits.
I think you've seen one ECHO, you've seen one funding model. A lot of different people are using a lot of different creative models. I think that a lot blend the state funding, grant funding, and philanthropy. So I think, again, people have just been really creative about how they've funded their individual ECHOs. I know there's a National Learning Collaborative on ECHO funding that Kansas is participating in. Missouri may be participating in that as well. Just trying to think creatively from a Medicaid managed care perspective about how we can fund ECHOs successfully.
Great, 2 more questions. Charles wants to know how the University of New Mexico Project ECHO helped you get your program going.
So University of New Mexico, Dr. Arora is really a mission-based guy. I mean, he's not looking to make money, he's looking to change healthcare, change the world. And because of that, he's been able to get some funding from some very large organizations like the GE Foundation and other large organizations to help him get the model out. So if you go on their website, they'll be happy to have you come down, and it doesn't cost you a dime except getting there and paying for your room once you get there. They'll provide all that training for free. And then there are 8 different super hubs that do the same thing. So Missouri, where I am, is also what they call a super hub. So you can come here. I've got some training scheduled for July and August if you live close to us. Although, you know, if New Mexico, the problem was that New Mexico, he has this goal of hitting 1 billion people, but they have a very finite, limited training center. So he had to get other places trained up to be able to do some of that kind of training. And we are one of those, and there are others. If you go to Project ECHO website, you can, it'll help you figure that part out.
I think that especially good thing about training was they really talk the talk and walk the walk. It's such a welcoming environment. I think it really brings home, you know, we're all here to help patients together, and I think that message really comes through.
Great. One last question before we turn the program over to Evelyn. Mary was at the Telehealth Summit in San Diego and sat in an ECHO portion of the summit, and her question is this project expanding its services to California and RCHs for profit?
I'm not sure, Mary, if we could unmute Mary Becky and have her talk and clarify this question.
She'll have to clarify via text.
Okay, so
here, hang on.
Sure. But it's open to everybody. So in Missouri, for example, any primary care provider can join. They do have to understand the rules of the game, that we're here in a non-shaming environment to help each other, not to call out that anybody you think is, you know, you're better than them. So there are rules with that, but we would let anybody join our ECHOs within the state.
Great. All right, Dr. Evelyn Nelson from the University of Kansas Medical Center is going to present some more information on Project ECHO.
Great, thanks. Just give me a second with the slides. Great. Well, thanks for the opportunity to share our perspective at the University of Kansas. I really appreciate learning from Rachel's presentation too. It's really encouraging to hear the success that comes along, especially as folks are evaluating and looking at outcomes across both the participants and the providers. I want to share our Kansas early experience with echoes. So my perspective and our center's perspective is a little bit different because we're a little bit newer in the trajectory. So I think you'll hear some similar messages, but again, we're still in the early stages of learning some of the echo lessons. I want to talk a little bit about our Pediatric Epilepsy ECHO, generously funded by HRSA and the American Academy of Pediatrics, our Pediatric Psychopharmacology ECHO, which we've dubbed P² because it's such a mouthful to say. Again, that one has been generously supported through some HRSA funding with a broader rural child poverty grant. Pain management ECHO that we're just starting in Missouri has been very helpful in helping us think through some of the outcomes that we want to look at as well. That is CX2 funded, a smoking cessation ECHO, and then just talk a little bit together about some ideas for the future. Rachel did a great job giving you an overview of the mission of ECHO, really to expand the capacity to provide our best practices across common and chronic illnesses in both rural and urban underserved areas, and then of course to monitor outcomes. I just want to say this is really what motivated me as a provider, and then more broadly our center and I believe our state to look at ECHO. I've been a telemedicine provider for over a decade now, so I see almost all my child psychology patients over telemedicine. But just almost as soon as we open a telemedicine clinic, it's booked up. So it's great. It really helps connect patients to the best practices and offers support for some families, but often there's such waits to get in, it's still a challenge. So ECHO is so appealing because it's to build the capacity in our rural and underserved areas to keep people close to home whenever we can, and then of course triage and when it makes sense that a family or patient needs to come to the academic medical center or other center or needs to be seen over telemedicine, that makes sense, but it just is really help us make best use of the resources that we have. This slide is also my reminder slide that ECHO is really a team sport. So it's really soccer, not golf. It's really thinking about teams of folks on the provider side. So getting in the room, your medical, behavioral health, pharmacy, health professions, nursing, that whole set of interprofessional folks who can really help, and each has unique perspectives with the complicated and complex illnesses that we're helping the primary care provider in considering options. And then it's also a team sport on the other side, where we're really thinking about, of course, connecting with the primary care provider or now the school, but also trying to work that with that whole practice to think through how can we talk together about cases in order to advance best practices. So I'll just start off talking a little bit about our Pediatric Epilepsy ECHO. Again, this was a little bit of a happy accident. We were at training in New Mexico, and the American Academy of Pediatrics was also there for training, looking at sites who could join them with pediatric epilepsy. So we were really fortunate to join with that team. Again, it's been a great experience to work with our Children's Mercy colleagues, really a fabulous epileptologist and his team, and then some of our behavioral health and educator experience on the Kansas side. That project also has great programs in Illinois, New York, and Colorado, and I know the AAP is looking for additional sites and bringing up some additional sites with that project. I neglected to put New Mexico on that slide too. They are also part of the Pediatric Epilepsy ECHO. So that project, the idea really is that pediatric epilepsy is one of, with kids, is one of the fastest growing populations affected by epilepsy, and it's often so difficult to find someone, especially with pediatric specific training in neurology, and really to find both that pediatric neurologist and a team of specialists to help implement best practices. that ECHO has really been held by the American Academy of Pediatrics Network. They've really reached out to their team of pediatric neurologists and groups there at the national group as they work through content for the presentations. And then, of course, working with the local teams to put their own spin and emphasis on areas that make sense in their own states and communities. And then really the idea is bringing virtual curbside consultation, bringing the expertise of the expert panel about pediatric neurology, and then of course the expertise of the community providers and their knowledge about that particular patient and the resources in that particular community. Again, all with the idea to maximize outcome. So we welcome you to join our Pediatric Epilepsy ECHO. It's on alternating Tuesdays between noon and 1 Central Time. I talked a little bit, it's a diverse team. So it's the pediatric epileptologist, advanced nurse practitioner, psychologist, pediatric educator, and pediatrician. I would highlight the educator as kind of a unique aspect of that ECHO, and I think it's really strengthened the approach where it's really looking at the medical, education, and family, all kind of the holistic full picture of the areas affected by pediatric epilepsy. Some of the early lessons have been pediatric epilepsy has been a little bit hard one to recruit for. What we found is some of our rural and especially our frontier primary care practices, they just don't see quite the prevalence of pediatric epilepsy as they see with some other common chronic illnesses. So it's been a little bit harder one to recruit. We have been really fortunate to recruit some providers who are just very passionate about best epilepsy care in their practices. So while it's been a small group, I think it's been a very dedicated group. And then with that, we've expanded to recruiting primary care and school nurse settings, and that's been a really nice mix, bringing a couple of different perspectives. And then yesterday, we just kicked off our P-squared Pediatric Psychopharm ECHO. And this, again, is part of a larger Telehealth Rocks project in our poorest rural region of the state. So our initial practices with that ECHO are part of the grant participants. Our largest participant is the largest community health center in Kansas. This is a really innovative set of practices in Kansas. And then that's paired with another pediatric practice and rural health clinic. Kind of driven by their interest, we'll be doing behavioral health topics over the next couple of years, but when we did needs assessment with the partners, they really said pediatric psychopharmacology and medication management was their first interest. So that's why we chose to lead with that particular topic area. The team with that includes 2 child psychiatrists that have delivered telemedicine care for a long period of time. I think that's a plus because they have experience working with our rural presenters and coordinators and keeping the broader rural communities in mind. So I think that's a real asset from our expert team as the child psychiatrist as well as pediatric psychologists and other specialists driven by the particular topic area. With that one, we really tried to model some of our case form off of what our child psychiatry team has used in other settings, and we're working with the community health center, especially to try to integrate some of the format into their electronic health record format. And then with this project, it's a broader telehealth project, so we're pairing the ECHO availability within telemedicine when it's needed and indicated. We're using the AAP's Pediatric Psychopharmacology book as a baseline and provided the book also to the providers just so it's kind of a 1-2 punch where they have the written material and then they also have the expert ECHO panel and really trying to reinforce messages. So a third ECHO that we're working towards is the pain management ECHO. And so the pain management echo, again, it's been grant funded through CX2. This is really part of a broader statewide pain management initiative that's been going forward since 2013. And that's been led by our continuing education department. So it's really pairing on-site educational events, both large conferences and then smaller community intensive conferences with ECHO. So that ECHO will start in September 2016. So right now we're in the process of finalizing our content and then recruiting 24 practices to be randomized either to an active or waitlist control. So the idea is we will have a waitlist control, but after the first cohort is completed, we'll complete a second cohort that then has access to the ECHO training. This is a really nice collaboration from our KU Med Center, our KU Hospital, and then also the American Academy of Pain Management. We've really strived for an interdisciplinary team that includes anesthesiology, pain management, primary care, nursing, behavioral health, health professions such as PT, and pharmacy, and then other specialists, really driven by the content and their availability. Of course, right now, this one, there's a lot of strong interest in the pain management echo with the recent CDC and other spotlight on opioid use and misuse. So this one, the recruitment hasn't been quite the challenge as some of the other echoes. We're really appreciative of Missouri's guidance. I think what they've done to link the claims data and outcomes is really makes a strong case. So we appreciate their help as we look at some of those metrics ourselves. And then we're also utilizing American Academy of Pain Management. It's a practice change measure. So looking before and after the echo at how the practices match up to some of those national metrics. And then we're also looking toward a smoking cessation echo. This was an R25 NIH proposal that was submitted in the fall. Unfortunately, it didn't score quite good enough, but we're still looking at revising and resubmitting this smoking cessation echo, as well as trying to look at some more local funding and philanthropy to help move the smoking cessation echo forward. The idea with this echo is really to look at those practices that are on the path to patient-centered medical home designation. And with this echo, it's pairing some pretty intense on-site training around smoking cessation and smoking cessation best practices, and then reinforcing that on-site training with follow-up echo sessions. And so the goal with it is over an 8-month period of time, really to help prepare the smoking cessation personnel at the primary care clinic to complete the tobacco treatment specialist certification. It's pretty compelling. Especially Kansas, we have very few tobacco treatment specialized certified folks in practices. So we think this would be a really exciting way to help move the bar and have more people trained in, again, the best evidence-based approaches with smoking cessation. And then we have some projects that are echo-like. There's some projects that are doing some similar approaches, pairing de-identified cases with didactics. So a couple of these are also more moving towards some echo work. One is our KU hospital-led stroke collaborative educational series. So they're, again, they have a pairing of some of the same didactics with case presentations. And then a second one is a pediatric behavioral health approach. This is a joint Children's Mercy Hospital and KU Pediatrics approach. And it really came about because we've gotten a lot of input from our local community as well as the state community about, wow, the wait times are long to get in. And the idea is to help decrease those wait times and then to help our own internal pediatrics folks and then hopefully expanding to the community and state to really help think through who can we help support locally with the best practices, and then who can we help then come to the specialist team for additional guidance. And really the idea is also, while there is that wait to get in, what are some things that can practically be done, and how can that patient be supported as they wait to come in to see the specialist team as well. So with that project, we're doing intensive on-site training in November of 2016, and then the ECHO will start in the new year. And then we're also pairing that with access to on-call consultation. So we're really hoping that package of approach will help, again, help us improve the wait times and again, expand that access to best practices. So I know I went through that pretty quickly. Again, it's just to give you an idea of some of the echoes that we've started and then are looking forward. I also wanted to look a little even farther into the future. We're really encouraged in our state, both by Missouri and other states' success with their legislature and other groups. Our state is, like I mentioned, working with the ECHO Funding Learning Collaborative and really trying to think about how can managed care look at ways to support ECHOs. So that's pretty exciting, and we're hopeful about that. And then I just wanted to end with a few ideas. I know Janine and others at the telehealth resource centers have a lot of innovative thoughts on this side of things, so they may have extra things that they add in. I think we're trying to think creatively about, could there be a telemedicine implementation at ECHO? So with the many folks that the TRCs help support with telemedicine implementation and technical assistance, would there be an ECHO model where people could share lessons learned and have support as they implement new telemedicine programs? A similar idea has been done with quality improvement echoes, and really as you learn quality improvement, then having the echoes help support implementing that. So I think that's a really neat idea, and hope to see that progress. Some other ideas that the telehealth resource centers maybe explore with ECHO is how to support resource centers customers who are thinking about starting an ECHO. So helping them, direct them to the best resources, some of the super hubs that Rachel mentioned, as well as the National ECHO, and then just helping think through, will the ECHO meet their need, and what resources are needed around starting an ECHO. And then finally, I think there's a lot of potential for the telehealth resource centers to help inform how do we pair some of the ECHO telementoring with telemedicine care. The resource centers have done telemedicine support for many years, so how could we think through what is the best approach or pairing of approaches with the particular situation? So again, the future's bright. So I think there's many creative ideas that the resource centers can help support with ECHO.
Thank you, Evelyn. That was very good. We have a question that you may have answered, but it probably deserves another look. This person is really interested in the pain management ECHO, and how could they start offering this specialty to their rural health clinic?
I guess from our perspective, I think it's just planning is crucial. So getting the range of expertise that you need and them trained and really taking the lead time to do that, I think is important. Rachel, I know you having implemented the pain management ECHO, you may have a broader answer to that question.
Oh, I was muted. Sorry about that. So I think that there are a couple things on pain management. It's a very popular ECHO. In fact, it's probably one of the most popular ones. If you take a look at the University of New Mexico Project ECHO website, you could probably start joining someone else's pain management ECHO to get an idea of what it's like, and then think about how to start your own. One of the things about ECHOs is that we really think it's like having one national chronic pain management ECHO is probably not some great idea, because as a chronic pain specialist in Columbia, Missouri, I'm not going to know what your local resources are in rural Northern California. So it's much better to do this regional approach. So we know that the specialists that operate in Kansas City, Kansas, and help manage the patients across the rural parts of Kansas, they know those resources. Same in Missouri. So we want to help people build regional echoes. So depending on where you are, we'd love to help you try to figure that out, talk about funding models and how much money it takes, because it really doesn't take that much. And in the meantime, you're certainly, could find one to join. So just get a hold of me or any of the other pain management echoes.
We have a question that says, I'm at the University Medical Service and Training Facility in Florida, focused on autism. Can we participate in the autism echo that you mentioned?
Is this mine, Janine?
Yes.
My question? Okay, so hi, Boyd Mark or Mark Boyd. I can't tell if your name is which way, but our autism echo, you can observe it, but because it's funded by the state of Missouri taxpayers, you can only participate if you live here or if you're going to pay your fair share of that. We have to be very, very careful with the funds that we have for our echoes, because they are directly from our state legislature and directly from the taxpayers of the citizens of Missouri. So I have to be super hyper aware of that. I will say that Dr. Kristen Soul has just received a $10 million grant to start Echo Autism at 10 additional academic medical centers around the nation. And I don't know for sure if one of those is in Florida or not, but I can help find that out. If you'd send me a separate email, I can get you that list. And again, you're welcome to observe our echo. But as far as participation goes, it's a little bit different story.
I might chime in. We had the opportunity to observe, and she is such a wonderful presenter. I think just to observe is great because she has such a great approach.
All right. Is there a website for ECHO?
Yes, I think it's Project Echo at UNM or something. Google Project Echo University of New Mexico. And then for information about Show Me Echo, it's showmeecho.com. Very
good. Thank you. All right. That seems to be all the questions. We're running out of time. Thank you to both of you. You did an excellent job, and we appreciate you sharing your time and expertise with us. So thank you, and stay tuned for next month. The National Telehealth Resource Center webinar series is on the third Thursday of every month. The next webinar will be about rural HIT, telehealth and technology challenges, one that you do not want to miss. And next, finally is your opinion of this webinar. It's important to us, so please participate in this brief survey by clicking on the link. Just let us know what you thought of today's webinar and how we can continue to meet your needs through this webinar series. So thank you for spending your valuable time with us, and we hope to see you next month. Have a great rest of your day.